Thank you, Dr. Sam. And it's a pleasure to be here on the telemedicine ground round. And I don't want to be like more than that late because we are short in time already. So actually, lipoprotein little a is something which is attractive nowadays. And let's see what we have. And this is my slide of we are privileged to provide care on lands that indigenous peoples have called home for thousands of years. And I wonder if you're going here, that's a real case scenario. I'm going to try to play this video and if you're hearing. I wonder if anyone heard that the video or not. Dr. Azam?
Khaled, you may want to increase the volume from your end. I think I'm hearing something, but it's very low. So like maybe the volume of the video needs to be
Okay, let
increased.
me just. Right. Okay. So I can describe this video for the audience that Sandra, she's one of the real case scenario of like a she had her father had a heart attack at the age of 50s, which is considered as a mature coronary artery disease in the family history. She wasn't know why he did die from the heart attack at that age, and she was doing literally everything right. She was having an exercise. She has been following a heart recommendation diet and all of the good things that's trying to minimize the risk factors. And even her family score, which we're using for as global cardiovascular risk assessment, she is just 1%. And she's very athletic. And one time she has been running in marathon and all of a sudden she experienced some sort of very chest pain. And I wonder if you can see here the coronary angiogram. Unfortunately, she had a severe chest pain and numbness at that same time. Her stress is negative. So the initial stress is negative. Her family physician was suspicious for all her symptoms because her symptoms were less typical. So that just a common cold. It's like I've been like feeling of anyone that just discomfort. All of a sudden, they decided to do a scan of stress, maybe stress nuclear test for her body. That there was some reversible ischemia at 80 category, and we had coronary angiogram. Actually, at that time, she has been like 39 years, and she decided to run foundation for lipoprotein level to increase the awareness. Unfortunately, now this lipoprotein level foundation is solved because of financial. I'm going to increase that's actually brought me to go to the objectives. So objective is understanding the structure of lipoprotein little a, and from understanding of the structure of lipoprotein little a, we can identify what's the biological significance of this lipoprotein little a, and exploring what kind of cardiovascular associated with lipoprotein little a, which is not something we are usually seeing yet in the regular checking up of the cholesterol or lipid profile. At the same time, identifying the critical lipoprotein little a levels. And here's the trick. We're going to then identify what kind of tricks here in identifying of the levels and how lipoprotein little a is going to be influencing the outcome of our patients and how we're going to implement that in decision making in the treatment of the patients. Current recommendations and the guidelines of lipoprotein little a in different guidelines. We're going to have like screening over that, navigating of complexity of lipoprotein little a assessment and the challenges, and whether we can target lipoprotein little a as one of therapeutic targets or not.
Khaled,
So,
we're
yes.
we're having a problem with hearing your voice clearly. So maybe you want to turn off your video, and maybe it's a network issue.
Okay. So
Yeah.
can you
Put your
hear me now?
We hear you, but it is intermittent.
Yeah. So let me just try maybe to change the network or so. Now it's better.
Keep going. Maybe it is actually.
Okay. So in disclosure, I have nothing to disclose. Um, so the history of lipoprotein little is not something new for the science to identify. It has been identified by Dr. Berg, maybe in 1963. He's from Norway. And there was almost scientific silencing over this lipoprotein literally for more than 20 years when Dr. Lon started to identify what's called a sequence or cloning of the sequence of LPA gene, which is responsible for lipoprotein little a manufacture or synthesis. Again, jumping to more than 20 years now, in 2009, there has been an increase on lipoprotein little a interest with some epidemiologic and genetic studies establishing the causal relationship between lipoprotein little a and cardiovascular disease. Then it has been started to attract implementation or attracting the guidelines, starting with the European Atherosclerotic Society, issued a consensus statement recommending for the screening of lipoprotein little a. And since then, there has been increasing interest in lipoprotein little a management and screening. So I wonder, Dr. Azam, do you hear me now?
We hear you. It is still a little choppy, so maybe you want to turn off your camera. That would help in improving the voice, hopefully, with if it is a network issue.
That's
Just a trial.
be,
So keep
okay,
your presentation.
just
Your camera would be maybe reduce the load on your
sure.
network.
Okay. Okay, could be like
Yeah,
that.
let's go back to your presentation because we lost
So
your presentation.
okay,
So you've changed. You were okay. Perfect. All right, you're back.
okay.
Yes, keep going.
Now,
Let's see
now,
how that
now
works.
we can see it. Okay,
Yeah, we can
perfect.
see your
Okay,
presentation. It's good.
okay, perfect. So that's actually the structure of lipoprotein little a, and from the structure, we understand what is the clinical significance of the lipoprotein little a. It is exactly as the LDL molecule, which is low density lipoprotein molecule, which is of the core of the cholesterol. And this core of cholesterol is mixture between triglyceride, phospholipid, oxidized phospholipid, and cholesterol ester. And from the core of this molecule, we can identify a very important molecule, which is oxidized phospholipid, is responsible for the pro-inflammatory effect of lipoprotein little a molecule. On the cover of lipoprotein little a molecule, there is identical to LDL molecule. There is what is called ApoB100, which is one of apolipoproteins because it is hydrophilic, partially hydrophilic, that's allowing carrying of the cholesterol through the bloodstream. And different from LDL molecule from LP little a molecule, we have this protein or A protein. ApoE protein is like a sequencing of critical proteins, which is sequencing of a number of like a cover or code for this molecule, making it more sticky. And because of the structure, unique structure of ABO is similar to plasminogen, it has got like a competitive inhibition for activation of plasmin. So it actually has got a pro-thrombotic effect at the same time. So we have got a pro-inflammatory from oxidized phospholipid and pro-thrombotic effect because of plasminogen-like structure. And then that's both of them is going to be contributing to the direct effect or biological effect of lipoprotein little a. So, if we're going to see that sequence of Kringle 4 routines, it's a sequence, and those copies actually is coded by LPA genes. So, lipoprotein little a is exclusively genetic determined. So, in another meaning, that we don't have like environmental risk factor, which can influence remarkably the level of lipoprotein little a, and that's going to be appearing at the time when we're going to discuss what kind of measures we can do in order to intervene or to try to decrease the risk of lipoprotein little a. I wonder if my voice now better or the same. We have the same problem, Dr. Azam.
It, it's better. It's better.
Okay.
Maybe you want to get a little closer to the microphone. That may help as well, but it's better.
This can be. If I close my microphone, I have no problem to close it, but you're not going to hear anything from me.
Sorry, I didn't mean you close. If you get closer to the microphone, it may help. Whatever microphone, closer to your computer.
Okay, right. Okay, yeah. So I wonder now it's better. I hope that's going to be better. So the lipoprotein right, the lipoprotein little a perfect has like multiple isoform, and I meant by the isoform is the size of the lipoprotein little a. It can be small, it can be larger, can be more large or remarkably larger. All of these size or isoform is depending upon how repetition of 4 type 2 sequence is present in the molecule of lipoprotein little a. So all of these, as we have been discussed, that is genetically determined by LPA genes, which are coming from both parents. So there are smaller form or isoform of lipoprotein little a, and they found that is inversely related to the concentration of lipoprotein little a. In another meaning, that the smaller the size of lipoprotein little, the higher the concentration of lipoprotein little a. That's the differences in isoform, and there's interpersonal variability between me and you and different people about the different isoforms which we are genetically inherited from both parents. And this slide is actually summarizing the effect of lipoprotein little a. It's running in the blood, over the bloodstream, finding some sort of crack in our endothelium and finding the way to subendothelial structure where it can attract the monocytes, which is getting inside of this cell wall and to be form a macrophage, and then it's going to be engulfed because those molecules have got the oxidized phospholipid, and the oxidized phospholipid is pro-inflammatory. Then the foam cell is going to be starting the process of atherosclerosis, sending smooth cell proliferation, and then there is increasing or inflammation of vascular wall, which lead to narrowing and eventually cracking of the endothelium and forming the acute coronary syndrome sequencing as well. They have found that the lipoprotein little a has been related to aortic valve calcification the same. So they are found in some sort of crack in the endothelium, and finding the way to the subendothelial structure and engulfed by the same process of atherosclerosis. Here, the macrophage is going to be inviting more vascular interstitial cells, which is going to be promoting osteoblast transformation, and eventually they're going to mineralize this area and causing an aortic valve calcification. From the structure because of plasminogen similarity, which is have got competitive inhibition with the plasminogen or fibrinolytic system, the natural fibrinolytic system, they promote more thrombosis and blood clotting. And eventually, the thrombosis having the acute Crohn. That's applicable for all the cardiovascular beds. I mean by all cardiovascular beds, we're talking about the coronary arteries, peripheral arterial disease, as well as cerebral vasculation. Okay. So there is a UK biobank study. Is it about 500,000 people have been involved to study the lipoprotein level and the cardiovascular risk. They found the following: there is a linear relationship between the level and concentration of lipoprotein little a and ASCVD, or atherosclerotic coronary vascular disease. So as low as 25 nanomole per liter, which I'm going to discuss the levels exactly, because there is some sort of inconsistency and learning or agreeing about how much we should say that this is a high risk of a lipoprotein level, as low as from 25 to 50 nanomole per liter, showing a small but significant increase in the risk of cardiovascular events. At the same time, as 125 nanomole per liter, which we have the most agreement from different societies that this is a real cutoff for the high risk should be reconsidered. They have been like an an allegation about there is some sort of racial differences between the white South Asian and black population who have the meaning what is the cutoff value. And through this UK biobank, they just identify that there is no differences, there is no racial differences can be regarded. So the high lipoprotein little a is a high lipoprotein little a, as well as the diabetes as its clusters for all of the cardiovascular risk. They found the people who are diabetic have got a stronger association between lipoprotein little a and ASCVD risk in individuals with diabetes mellitus. And coming from that, the clinical implications of UK Biobank, that the risk assessment should be considering lipoprotein little a as a continuous variable rather than relying for certain threshold. And race-based of lipoprotein little a cutoffs are unnecessary. The same, the diabetic patients might be requiring more close follow-up for lipoprotein little a structure. And now, lipoprotein little a has been identified as an independent risk factor for CVD. In another meaning, regardless to the level of your LDL cholesterol, regardless to how much your blood pressure is controlled, how much your diabetes is controlled, lipoprotein little a is considered as a risk enhancer. And very important to identify what's called a risk enhancer for cardiovascular disease when we are making some sort of global cardiovascular risk assessment. So there are certain risk enhancers, namely like family history, elevated LDL, CKD, and metabolic syndromes, which is clusters for hypertriglyceridemia as well, and specific to the woman, which is premature menopause, inflammatory disease in general, ethnicity, South Asian ancestry, and at the same time, the lipid has been identified that the hypertriglyceridemia, when the level is equal or more than 2 millimole per liter, is considered as one of the risk enhancer. And now I have identified the lipoprotein little a when the level is more than 50 milligram per deciliter, and very important here, the milligram per deciliter, which is mass reading, or more than 125 nanomole per liter, is considered as a risk enhancer. And from this diagram, we are going to identify that regardless to the Framingham score, which is appearing here at the base, when increase the level of lipoprotein little a level, you're going to increase the risk of ASCVD or the risk of acute coronary syndrome in general. And this slide actually summarizes what we have been emphasizing, that this is the structure of lipoprotein little a, finding the crack here in the aortic endothelium and finding the way for the subendothelial structure, harboring more smooth muscle proliferation and then osteoblast transformation. When transformed, the positioning of more calcifications and progression from a healthy aortic valve to atherosclerotic or calcific aortic valve, ending into aortic valve stenosis. And that's what's the summary from the cardiovascular risk factors. The lipoprotein little a is in close relationship with a general atherosclerotic cardiovascular disease and the aortic calcification stenosis. but it's not homogeneous through the continuum of ASCVD or atherosclerotic cardiovascular disease. They have found that the strongest relationship between lipoprotein little a is related to the myocardial infarction and calcific aortic valve stenosis. So as high as the level of 193 nanomole per liter, we have got 1.5 hazard ratio. The same for calcific aortic valve stenosis and progression of calcific aortic valve stenosis, even much less than this level, we have an association with that disease. There has been less association or moderate association between LP little a and the peripheral vascular disease, abdominal aorta, and the major adverse limb events, including an acute limb ischemia, showing that there is some sort of stepwise increase in the risk. The higher the lipoprotein little a, the higher the risk of peripheral vascular disease. And there was a weaker association between lipoprotein little a and ischemic stroke and heart failure, and even the cardiovascular mortality in general. In another meaning, there is some sort of association. But if you are going to find for 1.5 hazard ratio, we are almost doubling the threshold. So it indicates that there is some sort of association, but a weaker one. And eventually, there is no relationship between the lipoprotein little a structure and venous thromboembolism at all. And that's giving us a clinical implication that the people for myocardial infarction and calcific aortic valve stenosis and the risk of stratification, they have got a close relationship between the elevated LP little a and that risk or risk of progression. Ischemic stroke risk become significant with much higher, but thromboembolism, venous thromboembolism has no relationship between that disease and the level of lipoprotein little a. Furthermore, there are other risk enhancer for ASCVD, including the C-reactive protein. They found that the lipoprotein little a, despite that the pro-inflammatory action, it is acting as independent and incremental risk assessment beyond the level of C-reactive protein, regardless the level of CRP, high sensitive CRP. When you have a normal CRP and high LP little a, you have increased risk of atherosclerotic cardiovascular disease, myocardial infarction, and calcific aortic stenosis. Resistant risk despite the lowering of LDL. So it is beyond control of low density lipoprotein. All of the medications which is effective at LDL as a primary target, such as statins, PCSK9 inhibitor, bempedoic acid, and ezetimibe, all of these are considered as non-effective in controlling of LP little a, as we are going to see now. At the same time, as long as you're controlling LDL, still you have got risk of LP little a. And that's why we need a specific treatment for LP little a. So the value of being risk enhancer, we need to identify the people who have got elevated LP little a. Then we're going to target LDL and non-HDL cholesterol even beyond the threshold of the guidelines recommendation. So the clinical takeaways from that, lipoprotein little a should be incorporated into cardiovascular risk assessment models, along with the traditional one markers, which is LDL and CRP, as you know. And LDL cholesterol lowering alone is not enough to mitigate the LP little a risk. Aggressive lipid management should be given in early in life in the individuals who has got lipoprotein little a. So now we're convinced about the importance of lipoprotein little a. Who are we going to screen? According to the most consensus guidelines, they agreed about that universal one-time screening. In another meaning, at least a single lifetime measurement for lipoprotein little a is recommended for all adults. Ideally, this is a part of routine cardiovascular risk assessment. And that's going to be helping us to assist the risk of ASCVD, myocardial infarction, and calcific aortic valve stenosis. And that will, of course, intuitively will have got the effect of how harsh or how hard we should go after the other risk factors, as we will see now. Targeting the screening or high risk group, if we cannot like screening this one, we have to target at least 5 types of the patients. The individuals with the premature ASCVD, I meant by premature ASCVD, men less than 55 years or women less than 65 years. At least we should follow that lead. People who have got a family history of premature CAD. So you have a lot of patients who are just coming to your clinic and having a positive family history of premature CAD identified by like father, mother, sister, brother has got myocardial infarction. Less than 55 years in male, less than 65 years in female. You should see and evaluate lipoprotein little a to see your adequate threshold to go after the risk factors. Patients with recurrent cardiovascular events, even if they have got a optimal control in LDL, they have got a second time myocardial infarction, despite that he is on statin therapy, despite he is taking PCSK9 inhibitor, and individuals with unexplained aortic valve calcifications, especially when they are young in age, less than 50 years. Patient with familial hypercholesterolemia, of course. And just giving you an idea about the pediatric population, that elevated lipoprotein little a in the children less than 18, so it's associated with increased risk of arterial ischemic stroke. At that time, exactly, it's not related to predominantly atherosclerosis, but because of the structure of lipoprotein little a, which is plasminogen-like, it inhibits or impairs fibrinolysis, internal fibrinolysis, and making the prothrombotic factor. So it has some sort of recommendation of selective lipoprotein little a in high-risk children. When you have a father or mother has got an elevated risk of lipoprotein little a, as it is totally genetically determined, you can go after or making some sort of family screening for the level of lipoprotein little in their children when they have got ischemic stroke without known reason for the children or for the adult, even young adult, and the family history of premature atherosclerosis, cardiovascular disease, you have the eligibility to go and cascade the screening. And that has got important implications for why I should go after that. So the lipoprotein little a reaching the adult level by the age of 5 years and just minorly increasing until the early childhood. So at age of 5, whatever you have in your body from lipoprotein little a is going to be almost fixed. And awareness of about the elevated lipoprotein little a can influence parents to encourage the heart healthy habits. So from early lifehood to avoid trying to make some sort of weight management, avoid smoking and drugs. So the child is going to be, I understand that I have to act healthy throughout of my life. Guidelines-based management of conventional risk factors is crucial, of course. Diabetes, hypertension, dyslipidemia, smoking, all of these factors, we're going to try to go above and beyond even the guidelines. Lipid modifying therapies may be considered as a case by case basis. There's a long discussion, and overall and early detection on intervention may enhance the CVD prevention. So we are acting on prevention level. Now, considering lipoprotein little a measurement, and it is genetically determined throughout the life, we have 2 ways to measure it, whether through nanomole per liter, and that's preferred, as I'm going to describe now, versus milligram per deciliter. So nanomole is a molar. It's number of the particles of LDL, regardless to how much the size or whether the LP little a is small molecule or large molecule versus milligram per deciliter, which is a mass. Mass, it is more related to the size of lipoprotein little a. And as what I've been expecting, that conversion is not always directly because it is not It doesn't mean that you have got a large lipoprotein little a molecule, you would have a high concentration of lipoprotein little a in the blood. Clinical implication of the screening that the level above than 125 nanomole per liter, and that's general consensus, are considered as increased risk of ASCVD. Very high level, which is above 200 nanomole per liter, is significantly elevated, requiring aggressive risk factor modifications as a risk enhancer. And that's trying to simplify the differences between milligram per deciliter here and nanomole per liter there. So milligram per deciliter, it is a bit isoform sensitive. It depends upon how much the size of the LP little a. If the size of LP little a isoform is small, is intuitively is going to be giving you underestimating for the concentration, because there is an inverse relationship between the size of the molecule of LP little a and the concentration, the same as large ABO A or apoprotein little a. It gives you a concentration which is overestimation. That's why we would prefer to be nanomole per liter, because it is depending upon how much the number of the particles inside of the blood, and it is in direct consistency with the concentration of lipoprotein little a in the blood. And here is the different way of measurement, whether we are measuring with a mass, with milligram per deciliter, whether we're measuring with nanomole per liter, and of course, the crude one, which is variable cholesterol. We cannot depend upon the only cholesterol, because it's going to be measuring the cholesterol in LDL and LP little a and in HDL. It's going to be like very confusing. It's not an easy, it's complex, the matter of measurement. And it depends upon how much of Kringle for type 2 repetition. That's what's controlling the size. And this is what we have seen. So the take-home message from this measurement, LP little a should be measured using the isoform insensitive assay, using nanomole per liter. Reporting and conversion is not advised. So some experts suggesting conversion with multiplication by 2 or 2.3. It's not advised generally by National Lipid Association. And LP little a levels stabilized by the age of 5 and tending to rise in the postmenopausal women in general. And that's and the advice of the screening of the people, as we have been discussing with the family history. And now incorporation of the decision making, the use of lipoprotein little a as a risk enhancer. And that's the different guidelines. ACCHA in 2019 identified that LP little a equal or more than 125 nanomole per liter, favoring statin therapy for primary prevention in borderline and intermediate. So we are going beyond the guidelines advice, or beyond the levels of the usual guidelines. Okay, European Atherosclerotic Society in 2022 identified the same as the American Heart Association. Canadian Cardiovascular Society recommend even more strict level, that lipoprotein little a 100 nanomole per liter or more warrants statin therapy. And its continuum risk. In another meaning, lipoprotein little a less than 75 considered as a low risk, but 125 or more is high risk. Intermediate is going to be like requiring more close follow-up, especially in the postmenopausal women, CKD, and hypothyroidism. Coronary calcium score as one of the risk enhancer is another add-on, but not substitute. So coronary artery calcium score is strong predictor of ASCVD, but doesn't eliminate the LP little a risk associated. Even when we have coronary artery calcium score 0, still we have to look after the independent risk factor of LP little a, which indicates that's contribution for pro-thrombotic and pro-inflammatory mechanism. So what offers we can offer to control lipoprotein little a? To cut it short, lifestyle modifications, including exercise, including diet control, Mediterranean, is very important, but it has got minimal effect on lipoprotein little a level. At the same time, the high risk people who have got lipoprotein little a still need lifestyle modifications because they have got a lower risk in comparison. In comparison with the people who has got elevated lipoprotein little a without lifestyle modification. Statin therapy is targeting primarily the LDL as a therapeutic target and to decrease the risk of ASCVD. We are not eliminating the importance of statin therapy in control, but it doesn't lower the lipoprotein little a. It's even increase minimally the lipoprotein little a level. And to be frank, we are not sure what's the mechanism behind the minimal increase of lipoprotein little a with initiation of statin therapy, but it's not cause of discontinuation of statin therapy and protection. Ezetimibe, the same, and bempedoic acid, we don't have in bempedoic acid, it is in the United States. Even PCSK9 inhibitors, it inhibits the synthesis through such as evolocumab, alirocumab, and inclisiran. All of these are important to control LDL. It has got an effect on lowering of lipoprotein little by 20 to 30%, but not yet approved for this indication. Niacin has got almost, it's an oral medication, around 23% in decrease of lipoprotein little a, but it failed to show any significant importance in protection in cardiovascular events. Aspirin is a class 1 indication for secondary AVD, but now there is some sort of conversation about having a rule in the primary prevention and high lipoprotein little a, especially when you have the prothrombotic effect of this molecule. So what to do? Actually, the only the effective therapy for it is lipoprotein apheresis, which is currently the only FDA-approved therapy for high lipoprotein little a, and it is just limited for the people who has been diagnosed with FH or familial hypercholesterolemia and ASCVD. They have gotten ASCVD where the level of lipoprotein little a is equal to 60 or more. LDL at the same time equal 100 milligram, which is almost 2.2 millimole per liter on maximum therapy. And effective lipoprotein little a lowering and LDL is costly at this time. Now, what's going on? There is a new therapies, which I'm not going to go through those therapies in details. It's beyond the objective of this lecture. It's called belacarsen, having like LBA Horizon trial, which is antisense oligonucleotide, which is targeting the mRNA to decrease the synthesis of LB little a, which is occurring in the liver. Obilsarin, or it's like a small interfering RNA therapy. It has got the effect of lowering LP little a1 to up to 100%. All of these are ongoing trials in phase 3 and phase 2. And we have a very effective medications and even oral medication here. Mivalipin, which is an oral agent which is disrupting the formation of LP little a at the liver in the early stage and succeeding to decrease the level of LP little a orally to up to 75 to 80%. And all of these are premature study, and still we are waiting for the effect, whether as a primary prevention or secondary prevention. So take home message from this lecture is measuring lipoprotein little a at least once in adult. And risk stratification, we identified that the low risk of lipoprotein little a is considered to be less than 75 nanomole per liter. LP little a 125 nanomole per liter or more is considered as a high risk. In between is intermediate, depending upon the other risk enhancer. Clinical actionability that lipoprotein little a is risk enhanced and regarding the lifestyle changes and maximizing to go above and beyond the guidelines. The importance of family screening when we have a lipoprotein little a to go after immediate or third degree relatives. Lipoprotein is up to this moment is the only FDA approved and it's limited to FH and coronary disease or peripheral arterial disease patients when the regular or maximum lipid lowering therapy failed to control the LDL and LP little a. And that's my references. Those are my references, and thank you for that. I'm sorry for being a bit long, but there was some sort of technical challenges here. Dr. Azam.
All right, Dr. Ahmed, thank you so much for taking us over through this overview of lipoprotein little a. I think I have some ideas now what to do with it, which is great. I love the picture. Let's take questions from the group. If you have a question, please write it in your Q&A, or if you want to add it to the chat, it's your poll. Or if you want to speak up your question, just raise your hand. I will bring you in. We have a few minutes to do that. I have a question here from Dr. from Polypolis. If lipoprotein little a is very high, what LDL levels should we strive for? So interesting. So what would that change your direction to how aggressive you would be in your treatment?
It's great. Thank you for this question. Actually, that's the core principle for this lecture. When you have a very high in the absence of specific targeted therapy for LP little a, we are going above and beyond the guidelines. We're not be satisfied with the guidelines levels of 1.8 millimole per liter, for example, for the high risk. We will go beyond and lower. So we're going to adapt the lower is the better, theory at that time. So we're going to implement all the other risk factors targeting the hypertension, smoking, dyslipidemia, diabetes. That's the only, and implementing the aspirin even in the primary prevention.
Dr. Ahmed, with going aggressive, is there a target you would suggest for to get to, especially with the theory of like too low may not be good, and I don't know how true is that, but like the balance between going too low, or is there anything that's really too low in LDL?
Unfortunately, there is no clear consensus here about too low, how much we can go, and the other challenges regarding to the age specifics. So above 80 years, whether we're going to be concerned about going too low, we need the cholesterol eventually, and as a steroid, as like the backbone of our hormones, and there is no consensus at that level. But they are just advising to go above and beyond in global risk stratifications and lowering all of the other risk factors.
Amazing. I have Dr. Kurt. If you want to unmute yourself, Greg, sorry, and you can speak up your question. Yeah.
Well, thanks very much for your insight. About too low, I think we need to rethink about this a little bit. Just a comment first, and my question is that you're born with an LDL cholesterol about 1 or less, and you prosper well. All cells can make their own cholesterol except for mature red cells, and there's no data that too low is bad. And lifetime risk is important. By the age of 20, depending how you want to measure atherosclerosis, somewhere between 25 to 80% of people have some degree of this. So longer, lower is better. So LP little a enhances risk, and thank you for showing that. But also, Rob Headley doesn't think the standardization of LP little a is well done in Ontario. If you can comment on that. If I measure LP little a in different labs, will I get the same results? And also, it's there's different size kringles, and I've seen a lot of 90-year-olds live forever, and they still can have high LP little a. And I've seen some of people that are young that have a high LP little a, and that's a reason why they may have heart disease. Can we get smarter and saying, are there different fractions of LP little a we can look at in the future? At one time, we talked about small dense LDL cholesterol, but it turns out all LDL is bad. So I'm just wondering, in the field of LP little a, like people of Black ancestry have a higher LP little a, do they carry the same risk compared to a white Caucasian, etc.? So can we enhance this a little bit more and get more details on the size of the LDL or LP molecule and more insights to that? Thank you so much for your input.
Yeah, thank you for this question. Actually, it's a very important question. They have gone after the isoform size and tried to identify even the LPA genes, which are responsible for that. They have found that there is no clinical significance in terms of like risk assessment when we are knowing the size of LP little a isoform size in comparison with the real concentration and nanomole per liter or the particles, the number of the particles. They found that the number of the particles is in direct consistency with the concentration. Regarding to what we can do more to be smarter in this, I do believe that we are not undermining the role of the traditional risk enhancer, other risk enhancer, such as coronary artery calcium score and the same CRP, high sensitive CRP. They are still have got the rule there. So we are just adding more. I wonder it's going to be adding more complexity, but you can just imagine that we have around 20% of the population have got high LP little a. So we're talking about more than 1 billion around the world has got moving with high LP little a, and they are not having a myocardial infarction. So still there is a rule for the other risk factor enhancer and the traditional risk factors to targeting. Up to this moment, we don't have like an answer for exact age specific. Most of the ongoing trials, which is hitting lipoprotein little a, they are not targeting the old age yet. They are just more towards 60s and 50s, 40s, and in the primary prevention and secondary prevention. And we're going to wait for primarily the results, which is not appearing before, I think, the fourth quarter of 2026. That's the earliest for Belacarsin, I think, and up to 2029.
That's a great explanation. Thanks so much, Dr. Ahmed. I don't see any more questions unless you're seeing any on your end. I think even my system has.
Can you just comment on the standardization of LP little a? Have we done a good job at standardizing in Ontario?
Sorry, I missed this part of the question. Sorry. Unfortunately, no. And global wise, we were not having a good job. I'm trying actually to work with the laboratory here to try to move from milligram per liter or deciliter to nanomole per liter. And there's still inconsistency in this measurement. But the rule of thumb here, if you can measure the lipoprotein little a regardless, whether with milligram per deciliter or nanogram, nanomole per liter, please do and proceed forward until we are going to have further notifications from the laboratory research, and they are working now on globally. It's not in Ontario here. Globally, they are working now for consistency regarding to the measurement, and that's very important before implementation of therapeutic targets or like therapy specific for lipoprotein little a, to know what's the level we were and what the levels we are targeting and how much good we are doing to control the lipoprotein little a as initial screening and the follow-up.
It's also an acute phase reactions as well. So how far after, let's say, an acute heart attack or pneumonia, how far after these events should we be measuring it?
Again, there is no consistency in this regard, and even there is some sort, so there is an early findings and Belacarsin, I think, or I'll be sorry that I'm not sure about which one. There some sort of some sort of dissociation between CRP as an inflammatory marker and LP little a. So this is still in the gray zone, that we have no consistency regarding to how far we be away from the acute inflammation to be measured up to this moment.
Excellent. We are at 1 now. So thank you very much, Dr. Ahmed, for this overview, some quite a bit of new knowledge and very clinically relevant. So we appreciate your time. We apologize for the technical difficulty from our end as well. And however, we caught up, and I think it was a fantastic presentation and a great discussion. So we appreciate your time and appreciate everyone's who joined us today. And we'll see you next Thursday.
Thank you, Dr. Azam. Thank you. Thank you for our audience. Thank you. Appreciate it.